Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the deep dive. Today, we're analyzing a condition that, it really earns the title of a beast, and I don't use that word lightly.
No, it's accurate.
We're looking at a disease process that is just relentless, it's transmural, and frankly, it often defies the standard medical algorithms that we see working for other GI conditions. We are talking about Crohn's disease.
Beast is a very apt description.
Yeah.
It's a condition that just refuses to be put in a neat box. It's not just some surface-level inflammation.
Right.
It's this chronic transmural process that can strike anywhere from, the mouth to the anus. And for our audience today, many of whom are surgeons and clinicians, we want to move past the textbook definitions.
Yes.
We need to get into the weeds of why the pathophysiology dictates such high-stakes decision-making in the operating room.
And that's exactly the mission today, a really targeted review. We want to bridge that gap between the molecular why, the genetics, the cytokines, and the how, which is often a surgeon standing over an open abdomen at 2 a.m. making a critical call.
A very critical call.
But before we unzip this topic, we need to handle the housekeeping, the safety disclaimer.
Absolutely. We have to be crystal clear here. Everything we're discussing today is for educational reference only.
Only.
Medicine is local. Protocols vary by institution, by country. You should always follow your specific local guidelines and institutional protocols in your clinical practice. This is about understanding the landscape, not replacing your hospital's handbook.
Understood. So let's get into the mechanism. We often lump IBD into this binary of, ulcerative colitis versus Crohn's. But clinically, they behave like different species.
Completely different.
Crohn's just breaks the rules. So where do we start with the defining feature?
The defining feature, and the one that drives almost every single surgical complication, is that word, transmural.
Transmural.
Right. Unlike ulcerative colitis, which is pretty much limited to the mucosa, the surface, Crohn's penetrates the entire bowel wall. It goes deep. And that depth is what drives the fistulas, the abscesses, and the strictures.
And unlike UC, which is really a colon-only problem, Crohn's has no boundaries.
None. It can affect any GI segment. But statistically, you're going to see it hitting the terminal ileum and the proximal colon most frequently. That's the classic hotspot.
Okay, so knowing what it's physically doing to the gut wall is one thing, but let's talk about the drivers. Is this just bad luck, or are we looking at a specific genetic architecture?
It's a mix. But the genetic component gives us real clinical foresight. The biggest player here is the NOD2 card15 mutation. And this isn't just, academic trivia.
This matters in the clinic.
It really does. If a patient has these mutations, they're specifically predisposed to ileal disease. But more importantly for the surgeons listening, these mutations are a predictor of aggression.
So a NOD2 mutation is basically a warning sign for a really difficult clinical course.
Exactly. These patients tend to require surgery earlier. They're much more likely to develop that fibrostenotic phenotype, the scarring and narrowing, rather than just inflammatory disease.
Which moves us to the immune dysregulation itself. We know the immune system is misfiring, but what's the specific fuel for that fire?
It's a Th1 and Th17 cytokine-driven response. You have this overactive response to luminal antigens. Basically, the gut flora that should be harmless triggers a war.
A total overreaction.
And the key mediators are TNF-alpha, IL-12, and IL-23. These are the signaling molecules just screaming at the body to attack, and that leads to chronic injury.
Which explains why our drug targets are what they are. But before we get to treatment, we have to mention the environmental accelerant, the one variable the patient actually has some control over.
Smoking. It is impossible to overstate this.
Yeah.
Smoking is the single biggest environmental aggravator.
Yeah.
I tell my patients it's like pouring gasoline on a fire. It actively promotes the structuring B2 phenotype and the penetrating B3 phenotype.
So it pushes the disease from, manageable with meds to requiring a scalpel?
Precisely. It accelerates the progression toward surgery, and crucially, it massively increases the risk of recurrence after surgery.
Let's visualize the damage for a second. When we talk about transmural inflammation, what does that actually look like on the table or through the scope?
So if you're scoping, you're looking for skip lesions. You'll see a patch of healthy, normal pink mucosa, and then right next to it, deep longitudinal fissuring ulcers. This creates that classic cobblestone appearance.
Oh.
And microscopically, in about a third of cases, you'll see non-case-eating granulomas.
And those granulomas are the immune system trying to wall off the inflammation, correct?
Corrupt. And because that inflammation goes all the way through the wall, You get two main outcomes. One, the wall thickens and scars. That's fibrosis, which narrows the lumen and causes an obstruction.
Oh.
Or two, the inflammation burrows right through, creating a fistula tract into the bladder, the vagina, another loop of bowel, or even out to the skin.
Wow. Which brings us to the patient in the clinic. The presentation isn't always subtle. What's the classic triad we look for?
Crampy right lower quadrant pain, non-bloody diarrhea, and weight loss. That's the textbook presentation. But you have to look for the nutritional fallout.
Right.
Because the terminal ileum is the absorption site for vitamin B12 and bile salts, these patients are often B12 deficient. They have macrocytic anemia.
So it's systemic. It's not just a gut ache.
Far from it. You have to watch for the extraintestinal manifestations.
That's great.
Peripheral arthritis in the large joints is very common. You might see erythema nodosum, these painful red nodules on the shins, uveitis in the eyes, even primary sclerosing cholangitis affecting the liver.
And what about perianal disease? That seems to be a specific subset that's notoriously difficult to manage.
Oh, it's devastating for quality of life. It affects anywhere from 17 to 43% of patients, usually the ones with colonic involvement. We're talking complex fistulas, high intersphincteric abscesses, strictures. It turns sitting, walking, just using the bathroom into a nightmare.
Okay, so we suspect Crohn's based on the clinical picture. We need to confirm it. Colonoscopy is obviously the first step, but is it enough?
Endoscopy with ileoscopy is the gold standard for diagnosis. You have to get into that terminal ileum to see the cobblestoning and get biopsies. But for the surgeon planning an intervention, endoscopy is insufficient.
Why is that?
Because it only shows you the mucosal surface. You need to see the wall and what lies beyond it.
So we need cross-sectional imaging to see the plumbing, essentially.
Exactly. CT enterography or MR enterography, you have to assess the plumbing before you touch the pipes. Is there a stricture? How long is it? Is there an abscess hidden behind a loop of bowel? You can't plan a surgery without that roadmap.
What about biomarkers? We hear a lot about fecal calprotectin. Is that useful for the surgeon, or is it more for the gastroenterologist monitoring therapy?
It's useful for everyone. Fecal calprotectin is a protein released by neutrophils. If it's over 150, it indicates active inflammation. It's a great differentiator between active IBD and something functional like IBS.
So it helps you decide if the pain is from active disease.
Right. If a patient has pain but a normal calprotectin, you might hesitate to cut, because the pain might be from adhesions or something else, not active Crohn's.
That's a key distinction. Now let's talk medical management briefly. We know the goal is mucosal healing. How do we bridge them from diagnosis to stability?
Well, ideally, we induce remission medically. For mild cases, maybe budesonide or even exclusive enteral nutrition. But for the moderate to severe cases, which is what surgeons usually see, we're using anti-TNF agents like infliximab or adalimumab.
And for the really high-risk patients, the ones with the deep ulcers or the perianal disease?
We tend to go top-down now. Start with the biologics, early vedolizumab, ustekinumab. We want to hit it hard and fast to prevent that fibrosis from setting in.
But here's the reality check. Despite all these heavy-hitting drugs, the statistics on surgery are still incredibly high.
That is the hard truth. Up to 50% of patients will require surgery within 10 years of diagnosis.
50%, that's a coin toss, even with modern biologics.
Even with biologics. Because once a stricture becomes fibrotic, once it turns into hard scar tissue, no drug in the world is going to dissolve it. It becomes a mechanical problem that requires a mechanical solution.
A plumber's problem.
Exactly. Or the patient develops a fistula or an abscess that's just medically refractory.
So let's shift to that mechanical solution. This is where the philosophy of Crohn's surgery differs so wildly from, say, cancer surgery. What is the prime directive here?
Limited resection. That's the mantra. You have to remember, Crohn's is a panintestinal condition. You cannot cure it by cutting it out. If you treat it like cancer and take wide margins, you're doing the patient a huge disservice.
Because it'll just come back somewhere else.
It will come back, and if you've been too aggressive, you leave the patient with short bowel syndrome. You want to save every single centimeter of bowel you can.
So how does that philosophy change the procedure? Let's take a stricture. In colon cancer, we'd resect the whole segment. In Crohn's,
If we can, we do a stricturoplasty.
Can you walk us through that for the non-surgeons listening?
Sure. Think of it like widening the sleeve of a tight shirt. Instead of cutting the tight part out and sewing the ends together, we make a cut along the length of the bowel longitudinally right through the stricture.
Okay.
Then we pull the middle of that cut apart and we sew it up sideways, transversely. This widens the lumen without removing any tissue.
That preserves length. But are there limits? I mean, you can't do that on a foot-long stricture, can you?
Generally, no. Stricturoplasty is for short, fibrotic strictures, usually less than 20 centimeters. For very long segments, or if there are multiple strictures packed together, you might need a resection. But for classic terminal ileitis, the standard is still an ileocecal resection.
And I'm guessing laparoscopy is the default approach now.
Whenever feasible, yes. It speeds up recovery, reduces adhesions, which is really important because these patients will likely need more surgeries down the line. In a stable patient, we typically do a side-to-side stapled anastomosis.
That all sounds very controlled, but Crohn's is famous for not being controlled. Let's move to the high-stakes section, the emergency presentations.
Right, this is where the decision-making gets really difficult. About 6 to 16% of patients present emergently. You don't have weeks to optimize their nutrition, you have hours.
And the most common scenario is obstruction, isn't it?
Yes, obstruction accounts for nearly 60% of small bowel surgical indications. The patient is distended, vomiting, not passing gas. You know the picture.
So, do you rush them straight to the OR?
Not immediately. Not unless you suspect the bowel is dead. The management tree starts with a conservative trial. We call it drip and suck.
Drip and suck.
NG tube to decompress the stomach, IV fluids, maybe some IV steroids. You give the bowel a chance to calm down.
Because the obstruction might just be inflammatory edema rather than hard scar tissue.
Exactly. If the swelling goes down, the lumen opens up. If it's a short stricture that's reachable by scope, we might even try endoscopic balloon dilation. That has a 70 to 80% success rate in the short term.
But if that fails...
If they don't open up in 24 to 48 hours, or if you see signs of ischemia, worsening pain, fever, tachycardia, then you have to operate. And usually that means a segmental resection.
Okay, scenario B is the one that makes everyone nervous. Sepsis and abscesses. The patient is hot, their white count is through the roof, and the CT shows a big collection of pus.
The instinct is source control. Go in and wash it out. But in Crohn's, the rule is drain, don't cut.
Why is that? Why not just go in and fix the problem immediately?
Because operating on an inflamed, septic, malnourished Crohn's patient is a setup for disaster. The tissue is edematous. It's like trying to sew wet tissue paper.
The stitches won't hold.
They won't hold. The risk of an anastomotic leak is massive, so you use a bridge strategy.
A bridge strategy?
Yes. If the abscess is over 3 centimeters, we call interventional radiology for percutaneous drainage. We put a drain in, we start broad-spectrum antibiotics covering E. coli and Enterococcus, and we let the patient cool down.
So you turn an emergency into an elective case.
That is the goal. This strategy allows 50 to 95% of patients to avoid immediate surgery. Once the sepsis is resolved, we optimize their nutrition, often for 6 to 8 weeks, to get their albumin up. Then we go in and do a safe resection on a healthy patient.
But sometimes you just can't drain it.
Right. If the abscess is multiloculated, like a honeycomb, you can't drain it effectively. Or if the patient stays septic, despite the drain, then you have to operate.
And if you're forced to operate on that septic patient, do you reconnect them?
Almost never. If the patient is in shock or the contamination is bad, you do a staged approach, you resect the disease segment, and you bring out a stoma. You do not risk an anastomosis in a septic abdomen. Love to fight another day.
Which brings us to the absolute worst case scenarios, free perforation or toxic megacolon.
Fortunately, free perforation is rare, maybe 1 to 6% of cases, but it is a surgical mandate. If there's free air and stool everywhere inside the abdomen, you might even need a damage control laparotomy. Leave the abdomen open, come back in 24 hours.
And toxic megacolon, the name itself is terrifying.
It's a ticking time bomb. The colon dilates to over 6 centimeters. The wall becomes paper thin. If high-dose steroids don't turn it around in 72 hours, you have to take the colon out. A subtotal colectomy with an ileostomy. If you wait too long and it perforates, the mortality rate just skyrockets.
It's a sobering list of scenarios, but let's say we get through it. The surgery is done, the stricture is gone, the abscess is drained. Is the patient cured?
And this is probably the most critical takeaway for our listeners.
Yeah.
Surgery is not a cure. It handles the complication, but the disease process itself remains. The recurrence rates are, they're grim.
How grim are we talking?
Endoscopic recurrence, meaning we can see the disease coming back on a scope hits 90% in just 1 year post-op.
90%. At 1 year, that's almost a guarantee it's coming back.
It is. That's why we use the Rutgers score to monitor recurrence at the anastomosis. And it's why prophylaxis is so key. You don't wait for symptoms. High-risk patients should restart anti-TNF prophylaxis 2 to 4 weeks after surgery.
And we have to circle back to the lifestyle factor. If a patient keeps smoking,
Then they're just undoing all of your hard work. Smoking cessation halves the risk of clinical recurrence. It is non-negotiable. If you're a surgeon, you have to be the one to have that hard conversation.
it really sounds like the post-op phase requires a village. You can't just discharge them and say, good luck.
No, absolutely not. You need a multidisciplinary team. Gastroenterology, managing the biologics, nutritionists monitoring albumin, because if albumin is below 3, complication rates soar, and stomatherapy nurses if an ostomy was needed.
We've covered a massive amount of ground here, from the NOD2 mutations all the way to damage control surgery.
It's a complex landscape, but for the surgeon, the summary is clear. Intervene only when you must. Preserve as much bowel as you possibly can, and always respect the biology of the disease. It doesn't stop just because you cut out the visible problem.
It really highlights that tension, doesn't it? Between aggressive intervention when a life is at risk and extreme conservation to protect the patient's future.
Absolutely. And it leaves us with, I think, a provocative thought. With recurrence rates at 90% within a year, we have to ask ourselves, are we actually treating the disease, or are we managing the failures of the immune system one crisis at a time? The battle against Crohn's is a marathon, not a sprint. The surgery is just one hill on that very long course.
That is a very sobering perspective to keep in mind. If you found this deep dive valuable, please share it with at least one colleague or one friend today. This is complex stuff, and sharing the knowledge helps us all make better decisions for our patients.
And don't forget to check out the show's YouTube channel and social media pages for some visual aids on the surgical techniques we talked about.
Thanks for listening, and we'll see you on the next deep dive.
Goodbye.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.